Hi, so my name's Caroline Fleury, and I've been asked to talk to you about developing a complex intervention for a specific population. My research focuses on men with rheumatic diseases, particularly looking at developing a self-management support intervention. This is part one of two, so do come back for part two to hear the rest of the presentation. So the learning objectives today are to explain how I identified men with rheumatic diseases as a population of interest in need of an intervention, to give you an example of the research process that I've been through in working towards developing this complex intervention, and I'll also try and touch on some of the benefits and challenges of multidisciplinary team research. So why men with rheumatic diseases? Well, this actually came from my own PhD studies, where I identified that men with rheumatoid arthritis seemed to be struggling more than women with the condition. So just by way of some context, rheumatoid arthritis, it's an autoimmune condition. So rather than the wear and tear osteoarthritis that often people are more familiar with, it involves symptoms such as joint swelling and stiffness. Over time, patients can accrue joint damage. They experience symptoms such as pain, fatigue, and often live with poor quality sleep. Patients experience daily fluctuation in their symptoms, and it's also characterised by periods of flares and remission. There's currently no cure, although current medication is now much better, and you do rarely see the level of joint damage that you can see in the hands that are pictured on the slide there. The prevalence is around 1%, and the peak age of onset is between 35 to 50 years. So my PhD unexpectedly found that men seem to be struggling more than women. So I used a method called Q methodology, which I will explain in some more detail later, because I did use it again just with men. So for this, we asked participants to sort statements about their experience of living with RA across a normal distribution grid that looks like this. And then we statistically grouped the participants according to how they sorted the statements. So we grouped them in to participants that had shared views or shared opinions. And we found that one of the groups was nearly all men, and in fact all of the men in the study were in this one group, and they experienced life with RA as a constant struggle. So just as some examples, they highly scored statements such as being angry or frustrated because of their RA, and they also prioritised highly experiencing symptoms daily. And the quotes at the bottom are from the interviews that I conducted alongside them sorting the statements. And the statements they particularly disagreed with were doing self-management activities such as exercising, being symptom-free, and not letting their RA get them down. So this was only a small number of men. So this could have been just happened to be the men that took part in this study. So we needed to understand more about men's health to understand if this was worth further exploration. So as luck would have it, my director of studies at the time, Professor Hewlett, so she was a professor of rheumatology nursing, had recently examined a PhD with somebody who was a professor of men's health, Alan White, based at Leeds Met, or now Leeds Beckett University. So we talked to him and said, is this surprising that men are struggling more than women? And he said, no, absolutely not. It sounds very much like the pattern that sounds familiar to me from my work. So just to fill you in a little bit on some of the context, broadly, we know that men die at much higher rates than women, and in fact at every single age group, the ratio of male to female deaths are in favour of women. So more men are dying at every age than women for all types of causes of death. And this data is across the EU. So the blue bar for the EU and the green bar is just in the UK. And again, when we break this down by different causes of death, so from long-term conditions through to external causes such as accidents, we can again see that men have a higher ratio of deaths than women for all types of causes and throughout all different age brackets. So in terms of men's health, the sociology literature tells us that illness threatens masculine ideals such as self-control, self-reliance, stoicism, and so on. We also know from literature looking at specific long-term conditions that gender does impact the way in which men and women cope with. There are gender differences in terms of the impact of long-term conditions and the way in which men and women cope with those. And we also know that men tend to have less social capital than women. So this isn't just the number of friends, but it's the way in which they're able to use those friends and rely on those friends for different things, such as opening up or asking for advice and so on, or for help or support. The World Health Organization back in 2016, in one of their reports, said that to respond to gender inequities in health, men's health status and behaviour must be recognised as resulting as much from the social construction of gender as women's, and that they're committed to addressing the impact of gender on men's health and achieving gender equity in the European region. There's a widespread assumption that men are unwilling to take care of their health or consult a doctor for their health. The public narrative is that men will be strong, stoical, silent. They won't talk about their health. In a paper by Courtenay, he says that when a man brags, "I haven't been to the doctor in years," he's simultaneously describing a health practice and situating himself in a masculine arena. So a manly way of behaving is to not care about or not acknowledge that you care about your health. We know that women are more likely to use health services than men, but that actually may reflect that women use health services more during their reproductive years. So, for example, a recent study showed that women aged 15 to 80 years had significantly more GP visits than men. But within those years are the reproductive years where women are more likely to visit the doctor for issues around reproduction, contraception, and so on. However, a study in Lithuania did find that middle-aged women were more likely to have regular dental checkups, which of course doesn't relate to reproductive issues. So there may be something around women having a better relationship with health services than men. However, a more recent study has shown that if you control for age and morbidity, then actually men are no less likely to visit their GP than women are. So often the reproductive years or the issues around getting certain illnesses can obviously skew the data. And interestingly, a fairly recent study showed that if you follow up, or this study followed up men and women for 2 years prior to getting a diagnosis of 3 different types of cancers, and they found that there's no difference in the reporting of symptoms, or there was no difference in the visits to their GP. So they don't seem to delay in reporting their symptoms in comparison to women. They seem to be consulting equally in the lead up to a significant diagnosis. So this graph here shows men and women's reporting for colorectal cancer, and you can see the dots are close together, so there's no difference between the two. This one shows lung cancer, and this one shows malignant melanoma. So if there is differences in attending for GP services, it's not necessarily the amount of time they take, but possibly the reasons that both men and women may or may not delay. As you can see, as I'm sure you're aware, plenty of adverts or campaigns have targeted men and tried to encourage men to engage more with their health. But this victim blaming approach is generally unsuccessful. So we need to throw away the narrative that men are bad for their health or men don't engage with their health, and start thinking of ways that researchers or health professionals can provide services that men actually want to engage with. And the World Health Organization, so this comes from an EU report, this quote, but it's also reiterated again in the recent World Health Organization strategy document: men need their own health strategy. I've given you this for some background reading, so I won't dwell on this in lots of detail, but just to highlight that the World Health Organization Men's Health Strategy document highlights that we need to strengthen governance to improve policy, and to when we talk about not leaving anyone behind, that includes men as well as women. We need to make gender equity a priority for men's health, so not just what we can do for men, but how can we get men to help support gender equity across women as well. We need to make health systems gender responsive. We need to improve health promotion, and we need to build on a strong evidence base. So what do we know about rheumatoid arthritis and gender? If it seems as though there's an issue in needing to support men, what do we know about rheumatoid arthritis in men? We know that 70% of the RA population are female, so more women than men have the condition. We also know that women report more pain and disability than men, but this could be because the measures we're using capture what matters to women more than men. So, for example, this is taken from the health assessment questionnaire. I know when men have completed this with me for taking part in my study, so this measures the amount of disability that they have. For example, one of the items is taking a bath, and many of the men will circle, "I can do that without any difficulty." And when I talk to them, they say, "Well, it's because I don't take a bath, so I don't have any difficulty in not taking a bath." And you're potentially missing the nuance there, that they may actually be unable to do it because it doesn't matter to them. They're reporting that they don't have any difficulty. Men tend to report more distress than women at having to stop paid work. Women use a higher number and more diverse coping strategies than men to cope with their rheumatoid arthritis. Men report taking longer to adjust and adapt to their RA. And as I mentioned, my PhD work found that men struggle to cope, but they're not interested in the current interventions that we're providing in rheumatology. So this seems to point towards the need to focus on men, masculinity, and rheumatoid arthritis. So I had my director of studies. I'd roped in Alan White, professor of men's health. I also brought in John Kerwin, a professor of rheumatology, a medical consultant, for his perspective. Professor Karen Rodham, a professor of health psychology at Staffordshire University. And of course, I couldn't do this without a male patient partner who has RA himself. And then this was funded as a postdoctoral fellowship by Arthritis Research UK, who are now Versus Arthritis. So within the fellowship, I started with a scoping literature review to look at what's known about how men cope with RA, and the answer was very little. In fact, only 2 qualitative studies, fairly small, with single hospital populations, had ever focused on men with rheumatoid arthritis. And one of those, in fact, focused purely on veterans, which might be a very specific type of population. So we then moved on to conduct some qualitative research. So we were interested in the nature of the impact of RA on men and their preferences for a delivery style of a support intervention. So I conducted focus groups and also some follow-up one-to-one interviews to make sure that I'd explored their experiences in as much depth as I could. I don't have time to present the full findings to you, but the key points from the qualitative work was it was really important for men to maintain their masculine roles and identity. They used a range of coping strategies, some of which could be destructive. They were supported by their wives, but not their friends. And they engaged in they had preference, for practical rather than emotional support. So they wanted things, for example, that provided information rather than just coming. They didn't want to just come for a chat. So although I don't have time to go into it today, you can read the papers. So the literature review is published, the focus group study is published, and the interviews are published. And they also have some commentary on the different ways that men talk in the focus groups and the interviews in that paper. So a point that I did want to make was there is a generalisation that men can be strong and silent, but this can actually be quite misleading. So the men really did open up in the focus groups. They talked about crying, they talked about being in tears. and the interviews as well. You end up in tears, you just can't understand what's going on. It was so downing, it comes on so fast. And I just wanted to highlight that men often talked in the third person in the focus groups, but then in the one-to-one interviews, they personalised things a little bit more. So perhaps didn't feel such a need to position themselves against other men, but still in the focus groups, they were opening up about their emotions, just in a very slightly, subtly more guarded way. And again, this has been shown in depression, in prostate cancer, that men do open up given the right safe space to talk in. So it's potentially an unhelpful narrative that men are strong and silent, and it perpetuates this myth. And if we keep telling men that men are strong and silent, then they might feel unmasculine if they do open up. So we need to keep telling men that that it is perfectly normal and that men do talk and men do cry. So something else I wanted to pick up on was my patient research partner, Bob, was absolutely crucial to me throughout this. So, for example, when we were talking about the paper for the one-to-one interviews, we went off on a bit of a sociological and methodological tangent, and he said, that's all very nice for your CV, but what's the point of patient? What's the point for patients? How does that improve our care? And he kept bringing me back to what was it that actually mattered for patients. He also co-facilitated the focus groups with me, and there were a number of benefits to this. So he was able to share his experiences, which got people talking. Him asking some of the questions about emotions validated that these emotions would exist to people with this condition, and it often triggered people to open up, or the participants to open up, when they weren't at first opening up to me. And again, here's another example of how him opening up and sharing some of his experience opened the floodgates of the participants starting to share more of themselves. It frightens me what's in store for me. That's my biggest issue, day in, day out. He was also able to provide reassurance. Now, I could do this as a researcher, but I didn't have the same legitimacy as Bob did as a man with rheumatoid arthritis. So he provided legitimacy to being able to provide reassurance within the focus groups. So we'd conducted a narrative literature review, we'd conducted focus groups, interviews, and then we were interested in whether groups of men had similar experiences and coping styles. So to look at this, I used Q methodology. So briefly, Q methodology is the systematic study of subjective views. It's a way of quantifying subjectivity. It uses a combination of qualitative and quantitative techniques. And for this study, we took 64 statements from the literature review, from our focus groups and interviews, and we asked participants first to sort them into 3 piles: least like me, most like me, and a not really sure neutral pile in the middle. And then to use those piles to sort them again across a normal distribution grid. And then we interviewed them again. I interviewed them whilst they were sorting to explain the reasons for their sorting decisions. So the grid looked like this. So they're sorting from least like me to most like me, and they can have the majority of statements at the in the middle slots, and then they get the fewer statements in the extreme viewpoint slots. So it forces an opinion. So we analysed this to put the participants into groups that held similar opinions or beliefs. So we had 30 participants, and the neatest factor solution was a 2-factor solution. So those in the first group, or factor A, we had 14 participants, mean age of 67 years, mean disease duration 5 years. The HAQ is the Health Assessment Questionnaire, a measure of disability scored from 0 to 3. So these had fairly low disability, and the majority were taking disease-modifying anti-rheumatic drugs. The second group had 8 participants, similar mean age and disease duration to the first group, but these had higher level of disability, and half of these were taking our more aggressive biologic therapies. 5 sat somewhere in between the 2 viewpoints, and 3 sat completely outside of the 2-factor solution. So those in factor A prioritised focusing on positive things, finding ways of adapting, keeping active, asking for help, finding ways of maintaining their independence and control, and they didn't prioritise getting angry, aggressive, frustrated with their condition. Whereas those in group B felt frustrated and angry, and they internalised those feelings. They directed them towards themselves. They felt guilty about the impact it had on others. They tried to do everything as they'd done before they were diagnosed. They didn't want to ask for help. They didn't use gadgets or tools or devices, and they felt they'd lost all of their independence and control. So those in factor A we named acknowledge, accept and adapt. These participants were able to acknowledge their limitations, but they were able to accept their RA and adapt to it. Their ability to control certain aspects of their lives seemed to enable them to accept the loss of control that some parts of RA brought them. Whereas those in factor B we named struggling to match up to a macho ideal. These participants seem to be trying to hold on to their own ideal of what it means to be a real man. So they're fighting the impact of RA, leading to further pain and anger, which they were directing towards themselves. I don't talk about it with my friends. They'd think I'd gone soft if I did. Men don't cry, you know this, don't you? Not in front of anybody. You never would. And we think it's likely that we were under-recruiting those patients because it's likely that these would be the very men that wouldn't want to take part in research, particularly face-to-face research, particularly research with a qualitative component to it. So we're very aware that we may well have under-recruited this group. So we conducted a literature review, a qualitative phase, a Q methodology, so a form of consensus gathering that maintained individual differences. And then we moved on to a postal survey. So I'm going to leave that there. Do make sure you come back for part 2 to hear what we found in the postal survey and where we went after that. Thank you.